Good morning. It's my pleasure to be here this morning. My task is to talk with you about what's happening with Medicaid transformation, what we envision for the future, and also in keeping with the theme, I do intend to address what we're designing in our system to address access to care. But before I go into some of those details, I will respect the lights. I will. So green means I keep talking, yellow means it's time to kind of wrap it up. And unlike my colleague, red means get off the stage. I will respect the lights. But before I talk a little bit about the details of Medicaid transformation, I do want to first thank the organizers of this great breakfast. Representative Inscoe called it a very important event, and I agree completely because it sets the stage, I think, for some very important work looking into important issues, but it's also an opportunity for all of us to come together to focus on the things that are important in our system. When I was asked to come speak, Jenny placed this charge that I would come and tell folks that it's going to be okay. And she said, you can do that because people trust what you say. And I thought that's a big responsibility, right? That you're going to say it's going to be okay and people trust what you say. And then I realized that I felt that I can stand before you today and say that I believe it's going to be okay. I believe that because I have faith. I have faith in somebody much higher than all 400 of us, but I also have faith in us and in the people who are working in our system, all of you as providers, people who are accessing services, people that I work with in the department who are very committed, and you heard that level of commitment from our secretary. And I believe it because we have elected officials who care about people with mental health. And I'm grateful to be a part of the system. I come from a small town in North Carolina where there's 1,700 people. And then I live in the great city of Chapel Hill, where the only color that we care about is light blue. Sorry, everybody else. And so I do believe that things are going to work out well, but not just because I'm an optimistic person and that belief is not founded in reality, but because I believe that we're designing a system that is going to make things better. Now, I recognize, and I'll say in a few minutes, Linda, help me with the time, because just having a green light is good, but you don't know how far you're going, right? It's like, I can just keep talking forever. But when I think about the system that will work better, I think about the fact that we as mental health professionals have gone through a lot of change. Representative Inscoe have been going through change for 20 years. And we've made a lot of improvements, obviously, but there have been some pain points along the way, but I'm confident that moving to integration is what we need to do. We need to get out of a system where people access behavioral health care through one system, they get their other needs met for primary care through going to see their doctors. We need a system that's fully integrated, that focuses on the whole person, that pays providers for producing good outcomes, and that uses new and innovative funding payment reform in order to create new ways to reward where people is doing good work. And so I'm confident about our ability to do that. I trust myself, I trust the people that I work with, but also I trust you. And I know that we have elected officials that are going to do the right thing, make some hard decisions, but get us where we need to go, and I appreciate that. So let me talk a little bit about where we are, and I hope you trust too. I do. Let me talk a little bit about where we are. Most everyone in the room has heard that managed care is suspended, and you couldn't tell that by the amount of work that's going on. There's still a lot of focus on integrated care. We're looking at how we can advance those initiatives. How can we implement integration of care while we're waiting during this suspension period? We're also looking at how can we communicate better with beneficiaries. I've traveled the state, Deputy Secretary Kinsey talk about that as well, and we've had numerous opportunities to talk with people about this change. But with as much as we have done, there's still many hundreds of thousands of people who don't know what's going on. And so we need to do better, and we intend to do better with communicating with people who use the Medicaid program about the change that is coming, what will be the impact directly on them. What's going to change? What's going to stay the same? I will ask you to join me in letting people know that during this period of suspension of transformation, people can still go to the providers they've always gone to get the care that they need. That has not changed. We don't have a budget, but Medicaid still is operating under a budget that allows us to continue to provide services, and that's what we'll continue to do. We thank you for what you're doing as providers to make that happen. We're working, obviously, with our prepaid health plans, and there are certain things that they need to stop doing during this suspension. Without a budget, we obviously don't have some of the spending authority we need to do to reimburse them, but nonetheless, the prepaid health plans are focused on still engaging with providers, right? We can't implement managed care if we don't have an adequate provider network. If you don't have providers who are contracted, nobody gets access to care. And so that is something that the health plans can focus on during this period. What do you need to do to get providers willing to contract? We know that it's a challenge because there's uncertainty. People aren't sure whether it's going to happen or not. I believe that managed care will happen, but we need our prepaid health plans to continue to have those conversations, and we've asked them to do that. Also, with regard to, there's some important procurements that we're engaged in. The Ombudsman program is going to be a really important part of the design of our future, having an entity who's going to assist beneficiaries with solving problems. That's the role of the Ombudsman. And we're going to move forward with procuring the Ombudsman, and we're working on that right now. I know that many of you are concerned about tailored plans, right? Because we're doing a lot with our LME MCOs, and we're asking them to change. And so we intend to release that request for application so that the LME MCOs are clear about the expectations of them. What are we as a department asking them to do? How must they change in order to respond to that request for application? So you will see that we released, actually just, I think this week, on Thursday, we released a paper that sort of is intended to convey to everyone some important policy decisions about what we will expect of those tailored plans. And so I invite you to go out on our website and take a look at that. That paper talks about CFACs and the fact that we intend for the tailored plans to continue to have a role and continue to interact with CFACs, that there's a place for those CFAC members in decision-making positions, and the tailored plans will be expected to do that. We also talk in that policy paper on tailored plans about the role of counties and what does the governance structure need to look like for those tailored plans. And we believe that the governance structure that currently exists under 122C is where we need to stay. And so we're encouraging the LME MCOs, as they apply to become tailored plans, to make sure that there's county involvement in those governance structures. In fact, I think those boards have to be appointed by the Board of County Commissioners. We're working during this period of suspension as well on our crisis services. Deputy Secretary Kinsley spoke about that. We need a safety net system for people to access when they're in crisis and when they need to get services. And so we are requiring our prepaid health plans to have, I know I'm talking fast, I know that, but you know, there's this sense of urgency here. It's going to flip at some point to yellow. And I definitely want to let you guys know what's going on. But we've asked our prepaid health plans to have conversations with the LME MCOs and eventually with providers about how do we sustain the crisis system that we have today. We know that it's not perfect, but we don't need to do anything that undermines the availability of crisis services in our community. So now I'm going to focus on access to care. There are 1.5 million people on Medicaid who will go to managed care when managed care goes live. We already have more than 140,000, roughly, people in Medicaid who've already used a mental health or substance abuse service. So timely access is one of the most important things that we must ensure in our new system. And as I've gone through across the state over the past 3 years, one of the things that has been said over and over again is that we need services available in the local communities. We recognize that we have health plans that have come from across the country to North Carolina because they want to do business here. And one of the things we've emphasized is care is local. Care needs to be in the city and in the town, in the county where people live. And so access to care is paramount. We've also heard from the community that we have to build a system that makes sense, that leverages the experience that we have as a great state. We didn't just come to this table yesterday, right? It's been 47 legislative breakfasts. We've had LME MCOs who started out as area programs. And we have many of you as providers who've been doing this for a very long time. And so we need to build a system that leverages what works well for North Carolina. And we will do that. We also need a system, as you've heard, that breaks down silos. We don't need to continue this siloed system where behavioral health happens on one side of the street and primary care on the other. We will have a system that includes beneficiaries, advocates, and members of local CFACs and maintain their role in the public system. And as we've said earlier, the system will make sense for our counties as well. And one of the things that we've talked a lot about is innovation, right? We want to leverage innovation. We want to do new things. We want to sort of push the envelope. And so any efforts towards that needs to keep in mind that we have gone through reform already. And so we need to learn those lessons and apply those learnings to what we're doing, and we're definitely going to do that. So what are we doing in terms of requiring plans to make sure they ensure good access? One of the things we will ask all the health plans to do is they must give to us an access to care plan. And that access to care plan has to explain where are providers in the communities in which you're going to operate. And those providers have to be located in counties and in cities. At the residential level, we're asking them to tell us how many providers do you have that's going to take care of the population of this community. So looking at numbers is part of it, and the health plans will do that. The other thing that we're going to do, though, is look at realized access. It's not just enough to have providers who are contracted on your books, but we need to know how are people able to access care. Are people getting care timely? Can they get to care within a certain number of miles from where they live? And that's really important. Realized access is, are people able to get services at the time that they need it in a place that they need it? And one of the things I also want to emphasize, a requirement of the health plans as we look to go live with managed care, is that if you want to be, as a health plan, assign members to your health plan, you all know that when we go live with managed care, we will have this auto assignment system. So people will be able to choose the health plan, but if people don't choose or if they're not certain which health plan they'd like to work with, we will auto assign people to a health plan. But before we do that, the health plans must demonstrate to us that they have an adequate network of providers, that people can find a provider in their city and in their town. And if they can't demonstrate access, then they will not have members assigned to them. And if they can't demonstrate access, they will not be allowed to go live with managed care. We will slow their pace. And so I want to just emphasize that we mean what we say. We know that managed care contracts represent $6.5 billion of Medicaid funds. We take very seriously that. And that represents care that's going to people in North Carolina. And we're not just going to let folks sort of come in, show up, and sign the dotted line, but not deliver on their promises. That's very important to us. Just a few more minutes, and I want to emphasize a couple of other things that we think. Yellow light. What does that mean? Like 2 minutes? Okay, 2 to 5. Okay, good. I can do it. I'm almost there. I'm on page 5, and I think I only have a couple more pages. So the other things that are really important that support access to care is member choice. And so people will get to decide which of the health plans they want to manage their care. And individuals on Medicaid are going to make that choice based on which of the plans are contracted with the providers that I want to see. So choice is a very important principle that undergirds access to care. Care management and having care management embedded in the communities is another way that we support access to care, because care managers will help people get to providers. We will establish rate floors for providers. That's a way for providers, physicians, and physician extenders and other providers to be guaranteed that they will be paid a minimum amount of Medicaid dollars for the care that they provide. And then for tailored plans, what we're asking them to do, and please go out and look at that policy paper that was released on Thursday. We're asking them to establish relationships with community agencies, with the North Carolina Housing and Financing Agency, with other kinds of agencies that support people getting access to housing. We're asking them to establish relationships with VR and other entities that help people get access to jobs. So access to care is a part of the solution. Access to safe and affordable housing is another part of it. And access to employment that allows people to be independent, to control their life, is also important. Thank you. Thank you. It was more than the one clap. I appreciate that. All right, so I'm going to close now. I also wanted to go back to what I spoke to earlier about what it means to have your trust. I think we all have some level of trust. Somebody trusts us to do the right thing. And that's what we intend to do. We trust that we need to provide places for people who are living in group homes. Jenny and I talked about that today. People who are living in group homes who depend on state funds to support their care. We trust that we're building a system for veterans who have mental health issues, for people who are homeless. We need to design a system that works for most any of us in the room. I heard a statistic the other day that 7 in 10 Americans have either been on Medicaid or a member of their family has been on Medicaid. So it means something to all of us, not just those of us who work or those of us who use the system. It means something for our families, for our friends and our neighbors. And so although we're in a period of suspension, we're going to remain focused on those priorities and making sure that we create a system that can help people get care. Thank you very much.